Yo, yo, yo. Hey, guys, welcome back to another amazing edition of the Best Practices Show podcast. Today, I bring back one of my favorites. She's a regular guest on here, Katrina Sanders. She's one of the most gifted educators that we know of anywhere in dentistry. And today, we have a conversation about how do you create a patient-centric or customized care plan. And it really challenges how we think when we communicate with patients. So please listen to this and please share it with your team and then have a conversation with your team members and say, how do we start this process? You'll be glad you did. So hope you guys enjoy it and we'll see you soon. Hey guys, welcome back to the Best Practices Show podcast. You know, Jim, around here, I get to interview the coolest people in all of dentistry in hopes to sharing some great information to help you create a better practice and better life. And one of the people that I get to interview regularly, I don't ask her to come on the podcast. I make her come on the podcast. Her name is Katrina Sanders. And if you've ever seen her or been in the presence of her or watched a lecture or a webinar, you know, she brings it and she bends your brain, and she is here today. Today, we're going to be talking about a challenging concept in dentistry is how do we truly create a patient customized care plan or patient-centric care plan with the amazing Katrina Sanders. Thank you so much for being back. I appreciate you.
Oh, Kirk, it's always a pleasure. And I love that. Let's bend some brains today, shall we? In talking all things patient-centric care plans.
Yeah. Well, a couple things about you that I will brag about you. Number one, you're going to find that your favorite teachers get you to think. And Katrina is going to do that today. You also are a very unique human being that you combine excellent education, world-class education with humor and incredible patient stories. You know, the stories that Katrina will tell you during a lecture aren't really her stories. They're stories you deal with every day. You're like, oh my gosh, I had that patient yesterday, or I had that conversation in the hallway. And I also think you have a wonderful way of weaving the education, the humor, and the research in a way that puts you in a category of one. Oh, let me continue, is that you are a sommelier. Do you know?
Yes.
So like, if you incorporate education and wine, which is a great combo, you're the person to facilitate that. So did I leave anything out? Like what?
No, oh my, well, I'm also a dog mom. I don't know if that.
Oh my gosh. What don't you do?
I know. You know what? I'm a terrible singer. So if you and I ever find ourselves at a bar in Milwaukee and it's karaoke night, just buckle up for that one, because that's where you're going to see my weaknesses really come out.
I doubt that. And game on. That is, we're going to
looking forward to it. We're going to have to live stream that one.
Totally. So let's give a little background. Number one, who is Katrina Sanders? So why are you an expert to talk about this? What do you do? Who are you?
Well, thank you so much. I always love sharing this because with you, we've always talked about, you know, our love for the Midwest and, you know, growing up in Milwaukee and coming from that, you know, grassroots movement of, you know, I went to the dentist growing up as a child, had an amazing experience. Like I wasn't one of those individuals growing up that hated going to the dentist or had a bad experience. So, you know, fell in love with dentistry from a very early age. And when I decided to go to hygiene school, I kind of thought hygienists did what my pediatric hygienist did, which is, you know, polish teeth, put sealants on and things like that. And I will tell you, this is what's so amazing about our profession is that from when I started dental hygiene school to where we are today, this is actually 20 years later, the provision, the delivery mechanism of how we provide care to our patients it's so different. We've evolved. We have continued to revolutionize patient care. And so I think one of the reasons why people like to look to me as an expert in patient-centric care plans and developing that for patients is because we have to step into where evidence is pointing us right now. And I think sometimes dentistry shies away from that because when we talk about evidence-based care, we're talking about changing what we do. And the challenge with dentistry, particularly as a dental hygienist, I'm a periodontal hygienist by trade. As a dental hygienist, I was trained to basically do the same 4 to 6 procedures every hour on the hour. And I get my workflow down and it's, this is my drawer where I have my toothpaste and over here is where I do that. And then I Dentrix appointment book and and all these things. And when we start talking about revolutionizing things and evidence-backed and incorporating the future of progression in dentistry and healthcare and all these different wonderful buzzy terms, we also are talking about interrupting that flow that some hygienists like myself have had for decades. But here's one thing I really want to share. And I share this quite a bit. Down in the 1950s, they did a big campaign to help educate the general public about what dentistry was doing. And it was this campaign with a toothpaste commercial called Ipana. So I love sharing this because this is really the root of where dentistry and the concept of preventive dentistry came from. In the 1950s, this toothpaste commercial had this spokesbeaver, Bucky the Beaver. And in the commercial, he said, brush, with brand new Ipana, right? Yeah. And at the end of the commercial, he said, don't forget to brush your teeth with Ipana and see your dentist twice a year. Now, that was a campaign that was intentionally put out to the community to say, hey, we can be better stewards of your oral health if we see you, not when you have an emergency, not when your gums are exploding, not when your, tooth is so infected that your face is blown out to here, not when you're in excruciating pain and it's the Wednesday before Thanksgiving, which is always how that happens, right? Not all of those times. But if we could monitor you by having you come in twice a year and see you when you're not in pain and screen for these potential issues, that we could be better stewards of your health. That was the preventive model that actually was started in a 1950s campaign. That's 70 years ago. And yet, incredibly enough, here we are today, still doing a lot of the same procedures that we did in the 1950s, but our data, our evidence, our patient populations are also different. So now we have to take this mindset of patients thinking that they come in every 6 months for the no cavities, free cleaning your insurance covers. And we really have to step back into the model of what that campaign was, which is evaluating patients, looking at those risks, treating disease early before it hurts the patient, before the patient's complaining and coming in to see you. That we have screenings, we have technologies available to us. We have so many different opportunities to be able to integrate that. And so I think I've just become obsessed with that concept. I think it's so cool. And in being able to integrate that into my clinical care, it changes the relationship that I have with my patients. And I think that has been what has changed the trajectory of my career.
Yeah. And that's what makes you so great. But Katrina, you're bending my brain already. But that's the way we've always done it since the 1950s.
I know.
Why do you want to mess up a good thing? Come on.
Yes.
Now I'm joking. Those are the 7 most expensive words in business. Why is it so hard for the dental community to change?
Oh gosh, if I had the secret sauce for not only why, but how to change that, I would be a very rich woman right now. I'll tell you. And what I mean by that is, we learn in dental and dental hygiene school the way that school tells us we need to do things in order to pass our boards and enter the profession. And when we do that, we enter the profession, we start to change already the things that we foundationally learned to be true. And we do that because when I was in hygiene school, I was given as much time as I wanted to do a free cleaning on my patients. In hygiene school, I had 4-hour-long appointments. And if I didn't finish it in 4 hours, the patient could just come back and we could do more. But dentistry today, as of the recording of this podcast, dentistry today really has required the clinical application of what we do to fit into a one-size-fits-all model. And here's what I mean by that. As a dental hygienist, if I were to go and interview in a dental practice across the street, and I asked the doctor, tell me about your hygiene department, the doctor across the street would tell me, well, we allow you 60 minutes for a prophy patient. We allow you 60 minutes for a perio maintenance patient. We allow you 90 minutes for scaling and root planing. New patients are 60 minutes. Every single patient is fit within this one-size-fits-all model. All the stuff that you need to do on Mr. Jones needs to fit within this window of time. And unfortunately, that one-size-fits-all model doesn't work when patients are presenting with all different kinds of unique needs. Some patients, maybe that 60-minute appointment is going to work, but for other patients, we need time to educate them or their caregivers. Right. We need time to, sit down and explain to them about what this disease process is, why the new medications that they're on, their tobacco habit, their change in nutrition habits, their stress level, why all of these things are now augmenting their oral health. And I'll tell you this too, if dental hygienists treated patients in a 60-minute slot with their free cleaning their insurance covers 70 years ago, but today we have technologies like taking intraoral scans and 3D cone beams and salivary diagnostics and AI genetic testing, all these different things that we have available just to screen our patients, and then treatment modalities that require time. Now we have a greater challenge. And so the concept of dentistry wanting to stay tethered to the comfortable, the known, this is what we've always done, that's a fear-based mindset. Right. I don't want to change because this is what's comfortable and this is what we know. But you know this very well, Kirk, because you work with practices who are in that change, abundance, growth mindset, where the fears of, oh my gosh, this is going to be disruptive. It's going to change how we bill things. It's going to change the kinds of conversations we have. Patients might have questions. Patients might say no. I mean, all of these things that our little lizard brains tell us when the opportunity for change comes in front of us. Oh my gosh. I mean, if we can work through those things and say, but there are solutions for all of those things, and the result, the outcome, the opportunity is greater health, happier patients, healthier patients, and a more predictable outcome for our patients. And that's what we're here to do in dentistry, is it not? Is to make sure that our patients have healthier, more predictable outcomes, and along the way, if we can create an enjoyable experience for the patient, even better.
Totally. And so you're opening up a can of worms. This could be a 3-hour podcast.
I know.
What I love about the way you think is this, and if you're a listener, just think about this. What Katrina's really talking about, and this is what I believe about this great profession, is there's nobody better positioned to change the health of the world than the dental professional. Do you agree?
Absolutely.
You're not just cleaning teeth. You're not just making people's teeth whiter or straighter. You have the ability to truly change lives. We have t-shirts out here in this quarter, and Katrina, I'm going to send you one. Thank you to an incredible member of our community. They're called I Will Work for Purpose. It's an amazing powerful concept. People really want to work for purpose now more than anything. So that becomes a huge differentiator for you as a dental care professional. When you go,
Yeah.
there are people that fix teeth, there are people that change lives. We don't fix teeth here. We change people's lives.
Right.
That's number one. Number two, in a world where most people that are participating with PPOs are writing off as much as 42%, this becomes your way out. This is your ticket. Because what you have to do ultimately for people to pay your full fee and appreciate paying is that you got to step into the realm of truly being different and helping people with their overall health. And when that conversation happens, you're asking me as a patient to reach into my pocket, use my discretionary dollars, because you, Katrina, as my hygienist, have helped me understand why the hole under my nose is so important to the rest of my body. And that it becomes the gateway for how I live a better life, right or wrong?
You are 100% spot on. And I think that is the essence of where we are inside of the concept of preventive and active dentistry today, is the fact that we now know in the dental profession that periodontal disease, for example, is linked to 57 unique diseases and conditions of systemic display. Which means that, to your point, we're no longer just treating the 32 white things in your mouth. We go beyond that. And I think the new campaign, if I could get like a spokesbeaver for 2024 to do a brand new campaign,
let's do it.
Would truly be, let's do it, right? We'll start to get some commercial spots. It would be to educate the general public about what dentistry does for whole body health. And the data is out there about millennial spending. I can't scroll on Instagram. I don't know what's wrong with my algorithm, but I can't scroll on Instagram now without, being introduced to all of these different kinds of vitamins and minerals, that can help with this and can improve focus and can, women are magnesium deficient, so do this. So there's such a focus right now on health prevention. 23andMe is doing things like empowering the individual to study and learn about their genetics and things they can be predisposed to. People are doing at-home tests like Cologuard. There's a breast cancer at-home test now that you can take to evaluate your risk for certain kinds of diseases. And again, dentistry really stands at the forefront of so many of those things. And although we've talked about insurance before, you and I, and how challenging insurance is, there are CDT codes that are now being built for diabetes screenings and inflammatory marker screenings. So dentistry really is stepping into this space where every 6 months, I would love to see a world where dental hygienists every 6 months are doing things like screening for high blood pressure, screening for pathologies of the head and neck, screening patients for cardiovascular disease risk, taking A1C readings and screening for diabetic complications, that we can be the front line and then refer the patient as needed based on the things we're seeing. The problem right now is that we're not in a healthcare business. We're in a sick care mindset. Wait until it hurts. Wait until it's a problem. Don't take the nutritional panel until your hair's falling out. And then we're going to go ahead and test your blood and see if you're nutritionally deficient in something. But dentistry has been trained in prevention. We've been trained so beautifully in prevention. And that's where I think we have the opportunity to take our training, our education, and expand that to really serve the unique needs of our patients today.
Okay, you just gave me like 6 different podcast titles here. That is brilliant. I want you to unpackage this for us. So let's go back, because I have so many thoughts and this could get so dangerous. But if I'm a dentist listening, but Katrina, okay, so unpackage this. How do we create a patient-centric care plan? Like I'm already moving. I've got multiple hygienists, and break this down in a way that I can understand it and maybe share this with my team.
Yeah. So this is, I think, where, first of all, there are things that have to be standardized. And those are things like capturing your patient's medical history. That needs to be standardized across the board. Your patients need to be providing that medical history. We need to be capturing or asking questions of patients from a standardized mindset. And then within your practice, then you have the opportunity, once you capture this initial data, to really go on that unique patient-centric journey. This is where I think dentistry has solutions available, but we're not exploring them fully. So this is one of my favorite questions to ask a room when I'm standing in front of a room of dentists and hygienists. You know, you've got a patient who's a diabetic. They check that on the health history. I am a diabetic. Then they put in the medications section. They'll do things like, I'm on metformin, glyburide. They'll put the meds that they're on, right? And the average dental clinician, when they see that, I believe that they're going to look at that and assume that because the patient knows they're diabetic and that they are taking those medications, that the patient's diabetes is controlled. We assume that. Right. Oh, and then it gets even worse, because then some of us will ask the patient what their A1C is. What's your A1C, right? And we get an answer from the patient. And my question to dentistry all the time is that a correct answer? Like, how many of you actually think the number that your patient gave you is correct? How many of you think the number that your patient gave you is accurate and was measured within the last 120 days?
Right.
So right away, our standardized process that most dental practices across the United States will implement is we will ask a diabetic patient, are you taking medications? Are you measuring your vital signs? Great, that's good enough for me. Let's move on. And we like to use those risk factors as a reason why we need to do this periodontal treatment today. We'll say to the patient things like, well, because you're a diabetic, your gums are looking infected. And so I think we need to do this periodontal treatment today. It's called scaling and root planing. It's going to be a blast. We're going to numb you up. You're going to be super sensitive afterwards. For the rest of your life, we're going to have to see you on this periodontal maintenance thing that your insurance may or may not cover. But we have to do it because of how your diabetes is showing up.
Yeah.
And
it's so powerful what you're saying. Can I share a quick story based on
Yes.
So we had the good fortune of training an amazing team here last week, and I had a hygienist in the room, and she started crying, and she started explaining the why she loves working in this practice. Well, a patient came in, and the patient's blood pressure was off the charts. She's like, "We're not cleaning your teeth today. You need to call your doctor, or you need to go to a hospital." And she's like, the fact that I can put the flag in the ground and care for the patient, that we're not going to do this dentistry or continue this path because I care more about you. And the patient said, why not? I'm like, your blood pressure is off the charts. I thought that was like,
yes,
you hear stories like that all the time, but that's what you're talking about, right?
You're spot on. You're spot on. And I think the first issue with dentistry, particularly when it comes to vital signs like this, is that we're afraid of upsetting the patient. We're afraid that if we tell the patient we can't see you today, that we're going to upset the patient. When the reality is, what we should be doing is saying, hold on a second. This is bigger than your mouth right now. Your heart muscle is literally beating off the charts. Like this is a problem, and we need somebody to address this. And I hate to say it, my heart hurts to say this, but I know there are people listening who work in practices where even if the patient's blood pressure is off the chart, they are told, just clean them anyways. And that becomes another challenge, because then we start to question, why are we even taking this blood pressure on these patients?
Right.
Why are we taking it? Why are we recording it? If we aren't going to be stewards of the patient's health and become an extension of medicine like we truly are. So the bigger question that I have for dentistry is, once we know these things, once we know their blood pressure is high, once we know they have cardiovascular disease risk, they have a family history of cardiovascular disease, they have some of the other comorbid sign, stages, or symptoms of high blood pressure, right? Or elevated C-reactive protein levels. We know that they're pre-diabetic. Oh my gosh, how many patients are pre-diabetic? And so we know that. What are we actually doing differently with those patients? Right. And so dentistry's favorite answer is to say, well, we ask them what their A1C is, or, well, we tell them to go to the doctor and have their blood pressure evaluated. But the truth is, we also have tools in our tool belt in dentistry that have been well evidence-backed, well documented to help address cardiovascular disease or diabetic complication risk. So really what it should be is, why does your diabetic patient, why are you billing out the same CDT codes for your diabetic patient as you are for a non-diabetic patient? If you're telling that patient that the disease that's showing up in their mouth is linked to their diabetes.
Right.
So that's where I think we have the opportunity to really step beyond. When we go a little bit further, and I want to go a little bit further into this.
Please.
When we talk about patients who present with conditions that augment the body's ability to repair wounds, those are things like diabetes, rheumatological conditions, autoimmune issues, nutritional deficiencies, thyroid complications, cardiovascular disease, metabolic syndromes like obesity, depression, anxiety. I mean, the list goes. I feel like I just turned into a Pepto-Bismol commercial. Nausea, heartburn, indigestion, upset stomach. You know what I mean?
We can get our own rhyme going here for sure.
But I mean, when you have patients who have these things show up in their health history, we know that their wound response is going to be delayed.
Yep.
So what are we doing for those patients? What are we doing to change that? Dentistry's favorite answer is to say we ask questions and we educate them. And I don't mean to say that education is not critical, because hello, I absolutely believe in it. But I do believe that this goes back to the initial complication that we were talking about earlier. I believe that this is where dentistry stops. And this is where we should, instead of hitting the brakes, I think we should hit the gas pedal and say, oh my gosh, Mr. Jones, because you're pre-diabetic, I know that the inflammation in your mouth is accelerating your pre-diabetic condition. And Mr. Jones, did you know that if we can take and stop your gum disease right now, we have a 42% likeliness that we will stop your pre-diabetes from moving into full-blown diabetes. If we can stop the infection in your mouth. But Mr. Jones, that means that we have to take this seriously. And that's where dentistry, is non-surgical scaling and root planing going to be enough for that patient? Is it going to be enough?
Right.
Or are you going to sit back and educate your patient? Educate. This is what every hygienist loves to do. I'm going to educate you. So because you're pre-diabetic, your wounds are going to heal slower. So we're not going to see as good of a response. Is that good enough for your patients to say? When the reality is, we're also trying to tell the patient, we need to do this periodontal treatment to help improve your diabetic complications. So it's like this really weird two-way street. Which came first, the chicken or the egg? And ultimately, what are we doing for these patients? A pre-diabetic patient who goes in to see their primary care physician is receiving a workup. They're getting their blood work taken. They're maybe being put on medication. There are many pre-diabetic patients who are being placed on metformin as a preventive measure. They're being educated on nutritional counseling. They're being educated on low glycemic index food products. They're being educated at a minimum. They're receiving a pamphlet on the things they can do to help improve their diabetic complication. And that is specialized and unique to that patient. That's a conversation the doctor and the patient are having about the diabetic issue that the patient is presenting with. Yeah. Why are we not having this same exact conversation in the dental operatory?
Right. So here's my question to your question. What you're presenting makes perfect sense. It's compelling. It's exciting. It's motivating. And part of the challenge starts at the top, wouldn't you think? Like, number one, if I'm a hygienist listening to this, I'm excited. Like, this is a great opportunity. But number one, I need permission to go in this direction. Number two, I need the support from the top here that we can go in this direction. And everybody says advocacy is the future in healthcare. And I absolutely agree. But this is a clear path to that, where you're sitting shoulder to shoulder, knee to knee with people that you're like, hey, listen, I'm going to help you up this hill.
Yeah.
and becoming a valuable piece of your life because I care about you. Don't you think?
Absolutely. And that is what truly makes patient satisfaction and motivational interviewing outcomes improve. The data's been there time and again. When you can reach the patient and address them from their motivation, it becomes so much more valuable. One of the biggest issues with dentistry today is that we love to sit back and talk to our patients about how was your recent trip to Costa Rica and how are the kids in cheerleading camp? And oh my gosh, do you shop at that grocery store down the street? Did you know that they've got a sale on ground beef today? We love to have these beauty shop, barbershop talks with our patients to try to build trust. But the reality is that advocating for your patient and saying, I'm concerned about you, and here's my plan to work with you on this very unique, special plan. That's what changes the game. That's what helps patients understand that they have a partner with them, that they're not alone. Because although we don't typically deal with life or death for the most part in dentistry, we do have to tell patients bad news. This tooth has a cavity in it. This root canal is failed. This tooth needs to be extracted. We need to remove all your teeth and put you in dentures. This is a pathology that could be oral cancer. We do have to tell patients bad news, and we don't like to tell patients bad news, but we have to. So helping patients understand that they have a partner alongside them becomes so critical in patients feeling motivated, in patients returning for their future visits, in patients saying yes to treatment, in patients trusting us. And that has become such a critical piece in the case acceptance process that we're just now starting to unpack, which is really neat and gives us a lot of validation about why we need to be having these conversations.
Yeah. So I'm totally picking up what you're putting down. Let's go into the details of it.
Okay, let's do it.
Okay. Where do we keep going?
Okay.
I hesitate to say where do we start because we've already started.
Yeah.
I want to know like how you see this from a details side of things.
So here's what I first would like to challenge dentistry on. I believe that our conversations with our patients should sound very similar to the very conversations that our patients have with their physicians. So here's an example of that. I talk about her a lot. In fact, she's done some stuff with ACT. My sister is a foot and ankle surgeon. She's a podiatrist. And so as you can imagine, she sees a lot of diabetic patients that come in. They come in with diabetic foot ulcers. They need to have a toe amputated, part of their foot amputated, part of their leg, whatever's going on. And when she sits down with her patients and she has a conversation with them, she says things like, your A1C is making your foot ulcer worse. So the first thing that we need to do is look at what are the things that are impacting or creating a problem with your A1C. And interestingly enough, Mr. Jones, the infection coming from your foot ulcer is one of them.
Right.
So I believe that if we can control the infection, the source of the infection, we can improve your A1C. Those are conversations my sister has. She sees like 10 patients an hour. So 10 times an hour, she has this conversation. The infection in your mouth is making your diabetes worse. So we have to address that. She also talks to patients who have cardiovascular disease issues, and she works alongside vascular surgeons and cardiologists all the time. Patients who are on medications for their cardiovascular disease issues have these conversations with their doctors all the time. They know that they need to be monitoring their blood pressure. They know that they need to be taking medication in order to control their cardiovascular disease risk. They also know that if they aren't displaying the signs, stages, or symptoms of cardiovascular disease right now, that if they have a family history of it, that they need to be even more careful. I have patients in my practice who have a family history of colorectal cancer. They don't have colorectal cancer, but a member of their family did. And so colorectal cancer runs in their family. So these patients, in the conversations they have with their medical doctor, these patients are saying things like, so I should be getting a colonoscopy. So what are some preventive things I can do? High fiber diets, taking probiotics. Some of these things I can do because I know that is my risk. These are conversations they're having with their medical doctors. But we also know that if a patient has periodontal disease, that they have a high likeliness of having Fusobacterium nucleatum in their mouth, which is a bacteria that is directly linked to colorectal cancer. So dentistry has the opportunity to echo these conversations and say, if you have a family history of, if you have risk factors pointing to, here are the things that we are going to do. And again, that has to echo medicine. That's step number one. And I think dentistry is so fearful of asking patients questions about medical conditions. I remember when I was a faculty member and I taught at a local hygiene program, we had a great working relationship with the HIV and AIDS clinic in Phoenix at the Parsons Center. And so we had a lot of HIV positive patients come into the clinic. And perhaps that was a taboo topic in the 70s and 80s, but my goodness, we're beyond 2020 now. This shouldn't be taboo anymore. We shouldn't feel fearful or uncomfortable to ask our patients things like, is your viral load controlled? Are you consistently taking your medications? Is a doctor actively monitoring your viral load? How do you respond when you experience infection? How do you respond when you bump your leg on the wall and you start bleeding? How does your body respond? So I think there's opportunity there. Dentistry is still squeamish about asking about HPV, which, my goodness, we should be asking about. We should be asking our patients, have you, gotten your HPV vaccine? Have you been screened for HPV? Asking your female patients about, cervical paps and things like that to identify those risk factors. We should feel confident and comfortable asking these questions, because then that completely normalizes for the patient that this is a medical facility, because that's what it is. Right. So I think that's where we begin, I think, is having that conversation.
Yeah. And there's a lot of, we could go off on tangents, but like being bold, and it's not, I don't know if bold is just the right, but going there, what I mean? Like in a caring type of way, this is where it changes from being a superficial conversation to a highly personal conversation. Yes. And we're in a world where we're starving for significant relationships. We would care one person to really know us in a healthcare setting. And I don't mind sharing this, but my doctor, he retired, and I was so mad when he retired. But after COVID, this is what he said to me. He's like, okay, you're fat. We got to do
what?
Like, he said that to me, and I love him. And he just said, you've gained a lot of weight. I care about you. We got to do something. And he was like, and I knew he was getting ready to retire. And so I love him because he could get with me. And he's like, listen, this isn't good. Like, we got to do something. And I'm like, and he used that phrase, we got to do something. You got to do something. Yeah. And so,
if your doctor can't say it to you, who will?
Right. And I was
job is that, right?
Like, I wasn't. I'm not joking.
We all gained the COVID-19, didn't we?
But my point is like, he will probably, without question, be my favorite doctor of all time, because he went there with me.
Yeah.
And he did it in a very caring way, but he wasn't afraid to have the difficult conversation with me. And I knew behind it, he cared.
Yeah.
A lot. So I think you're opening up like the pathway to where the future of the exciting part of dentistry is going to be.
Thank you. And I'll tell you, the byproduct of having this kind of a dialogue is then the patient is sitting in that chair, and for whatever reason, a reasonable patient, when you have this kind of a dialogue, the next words that come out of your mouth should be, so these are the solutions. These are the things that I'm going to do, or that I propose to do to help you with this situation. The amazing thing about this is that the reasonable patient looks at that solution as something that helps them achieve an optimal health outcome, and not something you're trying to sell.
Right.
And I think that's the issue that dentistry has so much. We are so fearful that patients are going to say no and reject us because they see the things that we do as elective or optional. And let's be honest, there are things that we do in the dental operatory that are elective or optional. But when it comes to providing comprehensive health care to our patients, this is where we have to think bigger. And this is where we do have to integrate research. Funny story. I was on a plane. I was sitting next to a gentleman who, was kind of minding his own business. I flip open my laptop and I start working, and I'm building a deck for a client about gum disease or something, right? And he, happened to look over, see the gory pictures of whatever I was, doing my, content on. And he started to ask about, dentistry and all of these different things. And, he said, it's interesting because my dentist started to find cavities on the chewing surface of my teeth. And, I thought that I was a really good brusher, and I didn't realize that I had these cavities. They didn't hurt. So I told my dentist that I didn't want to have them filled until, they start to hurt. And he was asking me, some stranger on a plane who he had never met before, but he knows I don't have skin in the game. I'm not going to make money off of him, right? So he asked me, well, so should I have these fillings done? And I said, well, first of all, if your dentist diagnosed them with cavities, you should have the fillings done. But my question to you would be, if you're really prone to getting cavities on the chewing surfaces of your teeth, you should have sealants done. And he said, well, I had sealants as a kid, but I don't know, they must have worn off or something. And my dentist hasn't talked to me about having sealants done, as an adult. Why do you think that is? He asked me. And I said the obvious answer, which is, well, as an adult, your sealants aren't covered by insurance. So you have to pay for them out of pocket. And dentistry gets nervous to explain to you things that you might need that insurance isn't going to pay for, because we're afraid of what you're going to think about us or what you're going to say. So then he asked me, he was like, so what's the average fee for a sealant? Like if I wanted to have a sealant on my chewing surface of my tooth. And I said, $50 to $75. And he said, per tooth? And I said, yeah, $50 to $75 a tooth. And he said, and that would protect my tooth from getting a cavity on the chewing surface? And I said, yes. And he thought that to the average patient in your practice, that isn't a lot of money. This guy's sitting on a Southwest flight next to me. You know what I'm saying? Like we were both in the A boarding group, whatever. To him, it was like, why wouldn't my dentist talk to me about it? And so again, this is where I think when you have these unique conversations with patients, it really starts to kick open that door for more. And that's where we can really start to get prescriptive. So as a periodontal hygienist, that has allowed me to look at patients who are immunocompromised and say, because you're immunocompromised, we're going to implement X, Y, and Z. Because you are, rheumatologically compromised, I want to get ahead of that. Before I start kicking up biofilm and bacteria into your mouth, I want to do something to help start to treat that open wound so that I can get a better outcome. Because I know diabetics, I know rheumatological patients, I know cardiovascular diseased patients. I know these patients. I've seen them. I treat them every day. We have to be able to say to these patients, here are the special things I'm going to do because of your needs.
Yeah.
And that's where those now evidence-backed tools in your tool belt come out. That's where salivary diagnostics come in. That's where integrative dentistry comes in. That's where, AI technology, genetic testing, all of these different things come in.
Yeah. So let's go into those tools a little bit. And another thing I would say is, I think if you set your compass that I'm just going to help people and recommend what's best for them, and I'm really going to I'm not really responsible for how they react. I'm not responsible if they don't want to do this. I am responsible for telling them the truth and caring about them and giving them the best that I can, and then let the chips fall where they may. Does that help me at all?
100%. 100%. We are so afraid of the patient's, pun intended, inflammatory reaction. that it holds us back from telling the patient the things that they actually do need.
That was
And
pretty good.
that's thank you.
Really,
I'm here all day. Don't forget to tip your waitress. I think that's important because we're so afraid that they're going to say no or have additional questions when the reality is we should be leaning in when they have more questions. It means they want to understand.
Yeah. Yeah, absolutely. So let's keep going down this path. Maybe we can get a little bit more specific because I'm going to keep you all day if you let me.
So I'd like to share one of my favorite ways to do this. Okay. And I'm going to share something a little bit provocative with you that I think dentistry struggles with. So as a dental hygienist, I see my patient for their hygiene recare. They come in for their 6-month hygiene checkup. I take their x-rays, I probe them, and it turns out that they have gum disease forming. And I need to be doing, active periodontal therapy on these patients. This particular patient maybe was scheduled for their 60-minute appointment. So as a hygienist and hygienists out there who are listening, you know exactly what I'm talking about. You do the thing where you look at the clock and you go, okay, so I have 60 minutes with this patient. I'm 35 minutes into the appointment right now. I've just identified that the patient has perio. So we need to do SRPs on this patient. Patient's going to have to come back. I've got 25 minutes left. What do I do with this 25 minutes? Oh my gosh, that's a podcast episode in and of itself. What do you do with that 25 minutes? What do you do? And I will tell you, hygienists across the United States and around the world are all going to have different answers. Some hygienists are going to say, my doctor expects me to at least start something that day, at least do one quad. Some hygienists will say, my doctor requires me to do a prophy on that patient so the patient feels like they got something, and then we'll go ahead and reappoint them to start the SRPs next week when we have our 90-minute opening. Some hygienists are going to say, I'm going to take that entire 25 minutes left to educate my patient and get them scheduled. And it may be different from patient to patient as well, depending on how much time you have, how long it took you to educate the patient, how long it takes your treatment coordinator to come in and diagnose, all these things, right? But that is a major pain point for hygienists because once we identify that the patient has a treatment need, now we have to go a step further. So here's my favorite tool. And this is a tool that I use with very specific patients. These are patients who, and I'll go into some of the data on this, but these are patients who have active gingivitis. And that active gingivitis is either new to the patient, so they came in last time, they didn't have it, they have it this time, or it's been recurring and what we've been doing isn't working, right? So Every time you come in, every 6 months, we see this gingivitis. So we have to stop because what's been happening is not working in this case. Every time you come in, we continue to see this. So we have to do something different. This also works for your perio cases. Patients been coming in every 6 months. All of a sudden today, I find out that you have periodontal disease. We have to stop. We have to do something different. This specifically works for your immunocompromised patients, your diabetic patients, your cardiovascular diseased patients, your RA patients, your nutritionally compromised patients, patients with Sjogren's, celiac disease, any patient who is not going to respond perfectly to your treatment. This could also be in the AAP staging, a patient who's a grade C case, where we know that they have a rapid and progressive display of disease. With these patients, I look at my clock and I go, I've got 25 minutes left. Now I'm going to do something different. This is my tip for everybody. I let the patient know, I would like to scan you because we need to get a display of the architecture of your teeth. So I'm going to get an intraoral scanner. I'm going to scan you. What I would like to do is use these scans to create customized medicament or medicine delivery trays for you. Now, the important piece here is I'm letting the patient know that I am pre-treating them while their disease is being aggressively treated in my chair. So one of my favorite ways to describe this is almost like letting the dishes soak in the sink before I scrub them.
Right.
Or with my cardiovascular disease patients, I'm letting them know right now you have an open weeping wound in your mouth. And that open weeping wound is in multiple spots throughout your mouth. So these are the areas that we need to treat. So I want to get a medicament underneath the gum line area and into that gum tissue crevice to help start healing that wound. Why do I want to start doing that? Because it's going to start killing the bacteria in that area, which means I'm going to kick up less bacteria into your bloodstream. For my cardiovascular patients, for my patients who have a prosthetic joint infection risk, those are patients we're concerned about pre-medication. If I can control that bacteria in the mouth before it enters the bloodstream, that's going to give the patient and their systemic health a better outcome. For my diabetic patients, I let them know they've heard this before. When they had their toe cut off by my sister, they were told your foot wound is going to heal slowly and poorly because of your diabetes. So now I'm going to tell the patient, your gums are going to heal slowly and poorly. But if I can get these medicament trays and get you using them throughout your treatment with me, we are going to get better and more optimal outcomes. So now we go back to the appointment, right? We just spent 35 minutes. I said hello to the patient, took their medical history, took their vital signs, took the 4 bite wings the patient was due for, probed the patient. Doctor came in for an exam. Thumbs up. Yes, the patient has perio. We need to start perio treatment. I've got 25 minutes left. So instead of doing that $57 pro fee from Blue Cross Blue Shield or, whatever in the remaining 25 minutes I have left, which by the way, communicates something to the patient.
Right.
It communicates, I'm still going to do your free cleaning your insurance covers, and let's bring you back for the perio treatment, which tells the patient that the priority is the free cleaning the insurance covers and not addressing their periodontal condition. Because that's what we chose to do today.
Right.
So instead of that, I'm going to spend the remaining 25 minutes scanning the patient, sending the information out to Perio Protect Labs, and getting those trays custom made for my patient. So now doctor's billing out, $500 to $750 for these trays. Patient comes back in to start their SRPs, and now we're delivering those trays to the patient with the 1.7% hydrogen peroxide gel. This, for my patients, does a few things. One, it absolutely aligns with all of the stuff that I just spent all of this time talking about when I was talking to my patient about their medical history and why I'm concerned.
Right.
It also improves the patient's clinical outcomes. So what I want is for my patient to have SRPs done and then come back, or have their gingivitis 43-46 treatment done and come back and have a successful outcome, to have improved probing depth scores, reduction in bleeding tendency, fresher breath. That's what I want for my patient. And so it amplifies the success of my patient's treatment. The third, and everyone in dentistry is going to roll their eyes at this, but the third is that it's actually what the patient wants. Mm-hmm. I can't tell you how many times I work in a perio office. Very rarely do my patients come in and go, I have gum disease and I'm concerned. My patients are asking for their free cleaning, their insurance covers, and whiter teeth.
Right.
Those are the two things they want. So now I can use something like these hydrogen peroxide custom delivered trays with my patient, and we're both happy because not only am I improving the success of my patient's clinical outcomes, but that hydrogen peroxide improves whitening for my patient. So now they're getting both.
Amen. I love it. I love it.
I love it too. And my patients love it because then they're bought in. Then they're excited. They're involved. They have ways that they can empower themselves to be successful at home. Now we can extend the reach of our clinical care to the patient's home care. And that is what allows us to truly partner with our patients.
Yeah, this is a recurring theme, and tell me if you agree. Like, some of you might be listening to this and go, okay, all right, wait a minute. I have a lot of patients, and so I always say, Katrina, you know how you build an amazing practice? Just one patient at a time.
That's right.
One day at a time. You don't need to have success for 7, 8 patients a day. If you do what Katrina's talking about, we have success with one patient. We go through the Perio Protect process. We have now evidence or confidence that this is going to work with the next one and the next one and the next one. And it builds a collective confidence, don't you think? And over time, 2 or 3 years of this, you're changing an entire practice and an entire patient base. You're changing lives.
Yeah, you're spot on. And I think that's sometimes we do think it feels like drinking from the fire hose. When you learn about a product like Perio Protect or integrating probiotics into your clinical care or whatever, and you start to learn about all the use cases, all the different kinds of patients who are going to benefit from this, it does feel overwhelming because you really do realize this can impact the health of nearly every single patient who walks in and out of our doors. So some practices, and these are some of the practices that we've worked with at the ACT Dental campus, where people have come in, we've sat down, and we've gone through full day workshops of, okay, these are the clinicians that say, I want to split open my protocol and start from scratch. How do I do this? How do I do that? And that's where we do talk about, okay, so where will Perio Protect fall in line with your gingivitis cases? And what does that protocol look like? What does that framework will look like, right? Patient comes in, you see that they have gingivitis. Okay, so, how do you start those, trays that day? How do you, dispense the gel? How do you educate the patient? When do you reappoint that patient? When you bring them in for a re-eval? How often do you see them afterward? We walk through that and split that open for those practices. But you can also crawl before you walk, before you run. And so some practices will say, okay, let's integrate this for all of our scaling and root planing cases. Let's start there. Let's just start with SRPs. We're not going to talk about implant cases yet. We're not going to talk about gingivitis. We're not going to talk about full mouth debridement. Let's just start with our SRP cases. And to your point, what that does is it gives the clinician a spectrum of clinical experience with the product, hearing what the patients have to say, hearing their questions, and when you start to get that feedback, this happened for me actually with putting patients on water flossers. Once I started putting patients on water flossers and they came back and they were like, oh my gosh, this water flosser is a game changer. Katrina, I'll floss my gums and then I go in with the water flosser and more stuff still comes out. Well, enough times of hearing that from patients that I put on the water flosser 3 months ago, my goodness, that is data for me now as a clinician to now look at other kinds of patients who are struggling with, flossing or interdental care or furcation involvements or whatever and say, hey, my patients tell me this is what they notice when they use a water flosser. So the same is true with new protocols like what we see with our friends from Perio Protect. So to your point, absolutely. If this sounds like something that a practice would want to integrate into their protocols, the cool thing is there are a zillion ways to get started with something like this. And that really is the opportunity for us to be very customized and patient-centric with our care plans.
Absolutely. So brilliant. So a couple of things. I want to do 2 things. Number one, I want people to learn more about you, follow you, and Perio Protect and all those things. But before we do that, let's put a little bow on this. Like, bring us home with some final thoughts.
I'm going to bring it home. This data has been done and replicated many times, where they have looked at the number one reason why patients decline treatment plans from us, which seems like such a crazy concept in dentistry. Why is it that they would come in, they trust us enough to walk in through our front door, they sit down, we've got the lab coat on with the alphabet soup after our names and the certificates on the wall and all the things, and we tell them, you have this disease and you need this treatment, and they say no, and they get up and they leave. So this data has been done many times. Why is it that they get up and they walk out the door? And when you take a look at the data, it is unbelievable, the disconnect between dentistry and patients. Because I'll tell you, Kirk, I stand in rooms full of dentists and hygienists, and I ask them this question. Before I give them the answer, I say, why do you think they decline their treatment plans? Why are they walking out the doors? And the room erupts with answers ranging from insurance, they can't afford it, it's too expensive, they won't pay for it, they don't want to pay out of pocket, they just want the free stuff. And that is dentistry's response. That's what dentistry thinks. The truth is, resoundingly, the largest body of patients that decline their treatment plans do it because they don't trust their dentist. They don't trust their dental hygienist. And so the study of how you build trust has been so deeply rooted on customizing the patient experience, creating something that meets that patient's unique needs. It's been studied in business. David Horsager, in his book, The Trust Edge, talks about this forward and backward. The way that businesses build trust is to make the experience about the client or the customer. That is what dentistry has been tasked with doing, creating something that is unique and centric to the patient. And we are well trained in being able to do it. And so this gives us an exciting opportunity to really start looking at where can we build in or add in these patient-centric opportunities for excellence.
Drop the mic.
Boom.
Have you heard it? You're good. You're good. Now, if you're listening, I told you what was going to happen, and she was going to weave all of those things together. I just think you're an incredible gift to dentistry.
Thank you.
And
Thank you.
Dental teams. I learned so much just in the verbal skills side of things. Like, I'm totally borrowing a couple concepts from you today.
They're yours.
Oh my gosh. So, well, let's do this because I could keep you all day on this. And I want people, if they've never heard of you, they don't know where to find you. Where do I start? Like, I think you should always follow Katrina in social media. But if I want to learn more about what you do, where do I go?
Yeah. So thank you. Follow me on social. I am pretty active on Instagram. My Instagram handle is at the Dental WINEgenist. So yes, that is me integrating my love of dentistry and of course my training and love of wine as a sommelier. So the Dental WINEgenist. I'm also on Facebook as the Dental WINEgenist and LinkedIn under my name, Katrina M. Sanders. You can also find information about me on my website, www.katrinasanders.com. My website's kind of cool because I've got learning opportunities on there. So webinars that I've done, podcasts I've been on. Kirk, your face is all over my podcasting area because we're podcasting besties at this point. Articles that I've written, blog content that I've constructed, and of course, ways to engage and connect with me if there are, in fact, further questions. So feel free to connect with me. I always love hearing what are the things that really reached dentistry or really met the needs of the dental provider. So please connect with me. I would love to hear from all of you and learn more about how Kirk and I can get creative about fun podcasts to help support people in solving the needs in their practice.
You are the best. And Katrina's going to be back with us next month. See how I voluntold you?
Oh my gosh, I love it.
So, keep sending us suggestions. Katrina, stick around while we say goodbye to everybody else. But thank you guys for listening to the Best Practices Show podcast. Hey, if you enjoyed today, which I know you did, do us a favor. Hit the share button. Share this with your friends. Keep sending us suggestions for things you guys want to hear and see about. So I'll have Katrina back again and again and again and again and again and again and again. And we can ask her the difficult questions and she can provide some awesome answers. So again, just so grateful you guys keep showing up for this. We're going to keep bringing it and in hopes of you creating a better practice and a better life. So until we see you guys next time or you hear from us next time, keep watching or keep listening to the Best Practices Show. You guys enjoy your day.